morning, Chairperson and dear friends. My case, I will show two short case of coil embolization of the right renal artery pseudoaneurysm. 65-year-old female presented with chest and abdominal pain. ECG was normal. She is hypertensive and non-diabetic. Echo was also normal. Ultrasound abdomen was normal reported. Abdominal pain responded with analgesic initially. Then we thought something else. So why not do CT? So CT abdomen showed large pseudoaneurysm of the right renal artery. And this is we did angio from the radial route. Coronaries was normal. So this is a large pseudoaneurysm of the renal artery. We thought this is the cause for pain. So why not to embolize it? So in next sitting, we tried to embolize it from the femoral route because we wanted to selectively put the embolization. So we took, this is the, So this is the slip cap, 4 French slip cap, selectively enter into the aneurysm, confirm that it is in the aneurysm. So first confirm that it is in the aneurysm, and then gradually we put the Nestor coil. We had only 4 coil that time available. One is 12 into 14, another is 14 into 40. So 14. So other one is 10 into 14. So total we put 4 coils. And if you see it properly, there was a calcification in the upper lobe. What is only needed is the lower lobe coil embolization. And so selectively, as we do in the brain, there we use microcatheter. Here we use slip cap, which is a 4 French catheter, and put some more coil. Almost very easy work. This is uncontrolled coil, means you can't, so you have to be having the super selective in that your aneurysm. And aneurysm, after 3 months, we did the CT and we showed total thrombosis of this pseudoaneurysm. Some feeling is there, but since we had only 4 coil, we won't have more. So we did this enough. So coil embolization done by using 4, 12, and 14 millimeter Cook Nestor coil with complete thrombosis of the pseudoaneurysm over 2 months of follow-up. Patient is free of abdominal pain. Coil embolization exclusion can be done as in the brain aneurysm to prevent bleeding from the pseudoaneurysm. Thank you. Second case, can you rapidly put the second case? Okay. So similar, second case is a post-transplant renal transplant patient, and post-renal transplant and PTA plus stent, PTRA plus stent of the transplanted kidney was done outside. And after 6 months, the patient developed acute renal failure with abdominal pain, and there is a mass on the right flank. An ultrasound done showed subcapsular hematoma, big subcapsular hematoma. So we thought that during renal artery stenting of the transplant kidney, there was some perforation with the wire, and so that has caused the subcapsular hematoma and compression of the tissue, renal mass, and lead to acute renal failure with pulmonary edema. So this was confirmed with the 5 French, this is 5 French guide catheter from the other side, and then we took a renegade microcatheter, confirmed which is the branch which is involved, and then this is the renegade microcatheter. Yeah, confirm that this is the branch which is involved by the injecting through the renegade microcatheter. And then I think it's too slow. Yeah, so we put 2 1/8 coil through the renegade catheter, and it leads to total closure. I'll show you. This is the 2 coil. We thought if it won't close, we will put more. I think we put another 3 coil. This is 18 into 2 centimeter coil. and this lead to complete closure. Hematoma subsided. His renal function improved. He was normal. Creatinine was normalized. So simple wire perforation can lead to in transplanted kidney renal failure, and so renal artery stenosis has occurred because of perforation by PTCA wire during PTRA. Coil embolization is the treatment of choice in this case. And thank you.
Like your first case, we had around 2 weeks back. Patient had nephral lithotomy, and during that procedure, probably she had trauma. She had severe hematuria. Had to be given around 12 units of the blood, and then we embolized the branch from where pseudoaneurysm has formed, and patient recovered. So
sir,
after we have seen first time after nephral lithotomy, patient having pseudoaneurysm.
So it should be, if the patient comes with the pain with the aneurysm,
yeah, sure.
Embolize, yes.
Sir, in the time to come, there will be no coils available in our country, as you know. You know, the coils has been taken off the shelf. You know that.
I don't know.
As far as I know.
No, even we make coil in my hospital ourselves with the Teflon wire. Yeah. So no, here this is a fibered coil. This is Nestor coil from.
That's a
fibered coil.
Yeah. So you see, you cannot make for such a big renal artery aneurysm. So how you're not able to make the coil?
Nestor coil can come up to 14.
No, I know.
14 centimeters.
I know, but I think most of the coils will be taken off from the shelf. Is it like that?
Not really. We
are using.
Get all these things. If
all labs are so far having.
If doesn't work with this way, we could put the APV.
Okay.
Amplager vascular plug also.
Professor Buckley wants to make a comment. Yes, please.
I would just be cautious that 3 months is not a good follow-up for that.
Yeah, we'll continue to follow up, sir. But it has thrombosed.
Yeah, I know, but we've seen them thrombose, and then a year later, when you rescan them, they're back open again with coils in them. That's the problem. The coils don't really shut many of these down, and they reported incidence about 40% failure rate with coils in large aneurysms like that. So I would encourage you to rescan this patient in a year and make sure that's still shut down.
No, if it is decanalized or if say not thrombosed, we could put more coil, no problem.
No, idea is to have a regular follow-up,
yes,
6 months at 1 year and all, and see what happens. Thank you, Dr. Yadav, and I think we move on to the next case now.